So the paper was truly randomized. It was a computer-generated list of random numbers for patient allocation. The randomization sequence was created using randomization.com, and it was stratified with a 1-to-1 allocation using a fixed block size of 10. However, it's unclear if the allocation to the treatment groups were concealed, so there is no mention of allocation concealment in this paper. Since allocation concealment shields those who admit participants to a trial from knowing the upcoming assignment, the decision to accept or reject a participant should be made in ignorance of the upcoming task. Despite this paper being double-blinded, bias could still be introduced without a proper concealment at all stages of the allocation process. One cannot assume that just because the randomization was completed off-site, that allocation concealment was adhered to. The participants were, however, blinded to treatment assignment. The vitamin D3 and placebo were in liquid form and identical in appearance. There was no difference between the oils other than the intervention, which was undetectable to both the participants and those delivering the treatment. They were pre-packed in bottles and consecutively numbered for each participant according to the randomization schedule that was issued off-site. In connection with the inclusion, each participant was sequentially assigned a number by the responsible physician and received the corresponding pre-packed bottles. The supplementary data clearly states that those delivering the treatment were blind to the assignment for the whole duration of the trial, as was all the investigators measuring the outcomes. There is, however, some uncertainty as to whether the treatment groups were treated identically. A confounding factor in this paper, which was not addressed, is someone's diet. Because vitamin D is a fat-soluble vitamin, someone who's partaking in a ketogenic diet, for instance, who consumes large amounts of fat, would find that their vitamin D would be much more bioavailable than someone who is on a low-fat diet. This can greatly affect serum vitamin D levels and could therefore mean participants are changing the effect of their treatment during the study. Assessing the participant's occupation and or sun exposure should also have been considered. If a participant is a surf lifesaver and spends countless hours exposed to the sun during the treatment time, this would not have been confounded for. There are two forms of vitamin D that are able to be converted in the human body, but this paper is assessing vitamin D3, which is the same that's converted from the sun, meaning the sun could alter the exact serum levels they are testing in this trial. The paper mentions that follow-up was completely successful and the participants submitted daily questionnaires consistently for the whole 12-month period. Individuals who failed to do so were excluded from the study. Most post-randomization exclusions were due to patients failing to fill out the symptoms diary, hence there was no intention to treat analysis based on actual outcome data, so it couldn't be performed. One strength of this paper is that the outcomes were measured in the same way for both the intervention and the placebo group. The interventions were measured via an infectious score based on 5 parameters: symptoms from respiratory tract, ears and sinuses, malaise, and antibiotic consumption. Secondary endpoints were serum levels of vitamin D3, microbiological findings, and levels of antimicrobial peptides in nasal fluid. They were also measured in a reliable way. The primary outcome measure, a self-reported questionnaire, is a debatable tool amongst epidemiologists. However, the investigators reduced the chance of recall bias and increased intra-observer reliability by ensuring the symptom diary was returned daily. Epidemiological measurements of exposure relies on repeatability, and many experiments have shown that when people are asked to recall their diet, for instance, their episodic memory is only accurate for a few days. For this reason, asking patients to recall symptoms daily is increasing qualitative precision. Recall bias was also reduced by ensuring the participants were properly blinded. Observer bias, which is caused by a differential error, was also avoided by using the questionnaire, as the data collectors cannot ask questions or record information in a different way for cases and controls due to unintentionally probing more deeply, with either resulting in differences in the quality of data. Another way the outcomes were measured reliably is that the scores were logged prior to analysis, which reduces the chance of random error. The analysis was conducted 4 times during the 12-month period, each time being checked for repeatability. The measurements tool was also set before the groups were allocated in the planning of this trial based on a theoretical understanding rather than a practical one, which prevents the investigators from cherry-picking significant results and then presenting these as the findings. A weakness relating to the outcomes measured is that the infectious score outcome is a little hard to translate into clinical settings. It may have been more applicable to use different outcome parameters, such as the number of RTIs that an individual experiences or how long it takes to get their first RTI, as these have more clear meaning in healthcare. It would also be easier to compare the results with other studies and translate the results to patients. The infectious score cannot be generalized to efficacy for a patient, and it certainly cannot be generalized to efficacy in all environments. However, appropriate statistical tests were performed using the respected GraphPad prism, and a statistically significant p-value was found. The respected Mann-Whitney-U test was used for comparisons of age and vitamin D3, and Fisher's exact test was used for all other comparisons. These are respected, appropriate, and reliable statistical tests. There were no reported errors of statistical inference. The trial design was certainly appropriate, as the results were not only measured on symptom recall, but also biological secondary measurements. One of the strengths of this paper is that the results stem from a properly constructed randomized control trial, which carries all the strengths inherent to such a design, with loads of supplementary data about the blinding and randomization. This is something I've found quite hard to come by in many other randomized controlled trials. The lack of residual bias in this paper is purely due to the suitability of the study design and its adherence to a properly constructed RCT. Some other strengths identified in this paper is that it analysed vitamin D intake over 12 months, which covers all seasons. This would have been an important confounder, considering vitamin D is synthesized from the sun. It just should have specified amounts of exposure in relation to other participants, as mentioned previously. Also, this paper defined the primary outcome measure in the methods section quite clearly. I've found in quite a few RCTs that it is not always covered in detail, which raises questions as to how the results were developed. It should be a baseline requirement that the outcome measure is explicitly defined in the study protocol so that authors cannot misinterpret any results, and be clear that the primary outcome reflects the protocols they initially committed themselves to. There are a few more weaknesses in addition to the ones I have already established. So the paper did not define how an episode of an RTI would be defined. So this is problematic as there's too much variability in the interpretation of results. For example, if an RCT is assessing a drug for diabetes and the fasting glucose level that determines diabetes is different amongst two papers, these cannot be compared. For healthcare applicability and to disassociate this paper from errors, it should have been clearly defined. This paper also has a small sample size. According to biostatistics, in order to accept a hypothesis as accurate and to avoid errors, there should be a sufficient sample size in order to be more precise about where the true population value lies. The treatment in this paper was found to be effective, and the study identified the control as statistically significant. However, this should be replicated with a larger sample size to ensure that errors relating to insufficient statistical power can be ruled out. Nevertheless, this paper is reliable overall and extremely relevant.